Hello, my name is Kelsey Simpson, and this is my Mycoplasma Leprae case study for University of Kentucky Microbiology MLS 461. The patient clinical presentation is that of a 50-year-old Brazilian man who presents to his primary care doctor with minimal complaints, but complaints of extremity numbness, weakness, and loss of sensation in multiple areas. The physician immediately notices many large nodule skin lesions, hypopigmentation, a lack of eyebrows, and also visible deformities of the hands. The facial skin also appears reddish, smooth, tight, shiny, and thick. When asked, the patient states that the lesions and nodules have no sensation to them, but admits to recent decrease in functionality of his hands and feet. A little patient background is the patient recently immigrated from Paris, Brazil. He has no known previous comorbidities, diseases, but also never had any thorough medical care living in Brazil. He has stated that he has observed the lesions and deformities for around 2 years now, and that there were others within his community and dwelling that had similar lesions. Due to his socioeconomic status, the patient admits to primarily hunting wildlife for food while in Brazil. This included armadillos, red squirrels, rabbits, and various other animals. The physician initially swabs the lesions with routine swabs and sends them to the microbiology lab for culture. She's informed later that the cultures have no growth on blood agar, chocolate, PEA, or MAC. The blood tests as well were mostly unremarkable. A CMP, CBC, and CRP were ran. There was slight elevation of the white blood cells and CRP, but disregarded as minimal clinical significance. Physician decides to further investigate and perform a slit skin smear from an active lesion site. She also took specific PCR swabs and sent to another laboratory, as well as a peripheral nerve and tissue biopsy, and sent for analysis. The results of these tests showed various things. The first is that the slit skin smear shows innumerable acid-fast bacilli using the Zeal-Nielsen stain, as you can see at the top right corner. The nerve biopsy also shows thickening of nerve cells and numerous foam cells surrounding the nerves, including many macrophages around. And the targeted PCR swab did identify a variety of bacteria, including Mycoplasma Leprae DNA. The physician made a final diagnosis of multibacillary or leprotomous Mycoplasma leprae infection, which is also known as Hansen's disease. So what's the treatment? The World Health Organization currently recommends a 3-dose regimen of rifampicin, dapsone, and clofazime for a minimum of 12 months. This is due to recent developments of antimicrobial resistance among many bacteria, so singular drug treatment is no longer recommended. Unfortunately, with the treatment, this is a very late-stage diagnosis, as the deformities are very obvious and unfortunately likely present. They will need to be managed symptomatically by a variety of specialists. So how is the patient exposed? As many times, the specific infection source is uncertain, and there's a variety of contributing factors that could be the one cause. It's known that person-to-person transmission is a possibility, and he does mention that there are similar disfigurements within the patient's community, though it's impossible to test. Transmission from humans does require regular, close contact and is spread via droplets, so we are talking about somebody most likely living in close capacity with another infected and untreated person for an extended period of time. Another major possibility that is a source of infection is the zoonotic infection. Armadillos and red squirrels, part of the regular diet. There has been significant evidence that supports zoonotic transmission from infected armadillos and red squirrels specifically. While a lot of these cases did take place in the U.S., it is certainly a possibility that this has happened elsewhere. The patient prognosis and follow-up testing. The patient has been seen for multiple follow-ups and referred to infectious disease specialists as well. After 12 months of the recommended treatments, the patient's slit skin stains do now appear negative and have had the appropriate and expected amount of improvement. As mentioned, some disfigurements and nerve damage will remain post-treatment. Patient does continue periodic steroid courses to address nerve damage, the nerve pain, and gabapentin for any residual neuropathy. An overview of Mycoplasma leprae is very interesting. It was first discovered by Dr. Gerhard Armar Hansen in 1874. He's a Norwegian physicist and was searching for the causative agent of skin nodules within lepers. He was originally pretty unsuccessful and not convincing the rest of the medical community, though he took some drastic actions and later was able to prove it. This actually became the first bacteria ever to be identified that specifically causes disease in humans and is one of the most ancient known infectious agents, with human remains showing leprotic reactions as early as 2000 BC. Hansen's disease, or leprosy, generally just affects the skin, peripheral nerves, eyes, and mucosa. It is an intracellular, aerobic, acid-fast, rod-shaped bacilli with a characteristic waxy coating. This waxy coating is extremely important because it is a major virulence factor for it. Laboratory testing for this is impossible to culture regularly in cell-free laboratories because it is intracellular and very dependent on such conditions. The diagnosis is generally made using the World Health Organization criteria of clinical observation of skin hypopigmentation with definite loss of sensation, thickened peripheral nerves with loss of sensation, and a positive bacilloscopic examination, meaning the slit skin smears. PCR testing is newly available, and skin tissue biopsies are often used to assess the granuloma formation and leprotic reaction types, as there is a few different types. A Leperman skin test is an intradermal injection of antigen, and you are assessed essentially for your immune response, which is dependent on a delayed hypersensitivity reaction. There's also some serologic testing, which is not widely used, but is the phenolic glycolipin 1 antigen studied using ELISA or lateral flow immunochromatographic assays. Here you can see that the sensitivity and specificity of the slit skin smear test are such an important diagnostic tool, as it has nearly 100% specificity for leprosy and leprotic reaction diagnoses. While the other are not used as frequently, they are sometimes used in conjunction, but most importantly, the skin biopsy test will be used with the slit skin smear test in order for testing to be complete. As mentioned, you cannot grow this in a regular laboratory, and your routine lab workups will not be seeing this, though it is an important cause of blindness around the world, skin nodules, and clearly has a strong history of affecting many people. It continues to be around today and is even epidemic in some areas, so it is important to continue to watch out for.